Sushmita, can we start the recorded presentation?
On behalf of the ISN, I, Masaomi Nangaku, President of the ISN, would like to greet you. The topic of my talk today is oxygen biology in kidney disease. Before starting my talk, I would like to thank the core committee members of the ISN ESCON, Dr. Sandra Jan, the chairperson, and Dr. Manish, Dr. Rajesh Nair, Dr. Bhushanan Raju, and Dr. Bali. I also want to thank the organizing committee members, especially Manisha Sahai, the organizing chairperson, for inviting me to this important meeting. This is disclosure of my conflict of interest. Let me introduce about the ISN briefly. The ISN is a global professional association dedicated to advancing kidney health worldwide since 1960 through education, grants, research, and advocacy. The ISN, through its members and in collaboration with national and regional societies, engages 30,000 health professionals from across the globe to reduce the burden of kidney diseases and provide optimal health care for patients. Our vision is a future where all people have equitable access to sustainable kidney health. We do this for all our stakeholders by bridging the gaps of available care through advocacy and collaboration with our global partners. Building capacity in health professionals via granting programs, education, and research. And connecting our community to develop a stronger understanding of the management of kidney disease. These are the ISN grants and programs. In the last decade, ISN has supported many fellows, clinical research projects, local educational meetings, educational ambassadors, and sister renal centers and sister transplantation centers. Please let us know whatever we can do for you. They are the top countries in the membership in each region. Of course, India is leading the South Asia region. And Asia is a very important region because more than half of the world population live in Asia. The economy in Asia is rising rapidly. Asia plays a very important role in the ISN activities. Please encourage your colleagues to join the ISN. Now, let's talk about oxygen. Oxygen is very important because we use oxygen to produce energy. Without oxygen, we cannot breathe and we cannot live. As I said, oxygen is very important for our lives, and erythrocytes deliver oxygen to vital organs using its hemoglobin. Hemoglobin is not only expressed in erythrocytes. More than 15 years ago, we published this paper using many different methods, such as in situ hybridization, Western blots, immunohistochemistry, and so on, we demonstrated that hemoglobin is expressed by messenger cells. We speculated that hemoglobin in messenger cells serve to reduce oxidative stress in glomerulus. Straub and colleagues published that endothelial cell also expresses hemoglobin alpha, and hemoglobin alpha in endothelial cells regulate nitric oxide signaling and vascular tone. This paper was published in Nature about 10 years ago. This paper was published this year. Zhang and colleagues showed the hemoglobin is expressed in chondrocyte, and hemoglobin in chondrocyte serves as a defensive mechanism against hypoxia. If anemia develops, oxygen delivery to vital organs decreases and results in many symptoms like fatigue, dizziness, and so on. This is the analysis of the ISN INET CKD cohort. As you can see, the levels of hemoglobin decreases as eGFR decreases, CKD advances. Women tended to have a lower hemoglobin value compared to men. However, the difference got smaller in more advanced CKD. This is also the hemoglobin distribution among individuals with CKD in ISN INET CKD cohort. Patients with diabetic kidney disease showed more severe anemia compared with patients with CKD due to other entities such as glomerulonephritis, polycystic kidney disease. How are we treating these patients? This is the analysis of the Indian CKD cohort, ICKD cohort. In anemic patients recorded in this cohort, iron was given to 31% of the patients, and ESA was given to 3% of the patients. This may not be optimal. We may have to treat these patients in a more appropriate manner. We have the same situation in Japan. In Japan, we developed JCKD database. This is a nationwide multi-center electronic health record-based CKD database in Japan. In Japan, many different hospitals uses different types of electronic health record. Using this system, which is called SSMIX2, we can automatically standardize the data recorded in this database. And the central server incorporates the data of many big hospitals automatically. Currently, we have the data of more than 200,000 CKD patients in this database. We analyzed this database to check the status of anemia in CKD patients in Japan. As you can see here, the anemia levels progressed as the CKD G stage and advanced. In addition, about 1/2 of the patients achieved the optimal ranges of hemoglobin recommended by the guide. In addition, Even in the CKD stage G4 and G5 patients, only 12% of the patients were treated with ESA. So we should treat these patients in a more appropriate manner. Anemia is associated with many symptoms, as I said. This is analysis of the NHANES of the United States. CKD and anemia were associated with impairments in physical functioning and reduced physical activity, as we expected. This is the analysis of the veterans with incident stage G3 CKD. And the analysis of these patients showed that anemia itself in CKD patients is an independent risk for dementia. Anemia is also a risk for kidney failure or death. We have to treat these patients with ESA in an appropriate manner. But when we treat these patients with ESA, ESA hyporesponsiveness is always an important issue. ESA hyporesponsiveness is associated with poor prognosis. This is the regional variation of ESA hyperresponsiveness shown in the ASCENT-D study, which I am going to talk about later. The ASCENT-D study is a large clinical trial of HIF-PH inhibitor. ESA hyperresponsiveness ratio varies among different countries. And for some reason, some unknown reason, ESA hyperresponsiveness was more common in India and Canada compared with UK, Australia, or USA. We do not know this reason. It is also important to understand that ESA hyperresponsiveness is not permanent. It can be transient because ESA hyperresponsiveness is often caused by chronic inflammation. If inflammation improves, ESA hyperresponsiveness can also improve. This is the analysis of the DOPS study, and we showed that the patients moved around among the different categories of ESA hyperresponsiveness. So if we can find a cause of chronic inflammation in patients with ESA hyperresponsiveness, we have to remove that cause. In 2020, the ISN celebrated the 60th anniversary, and the ISN chose 60 top breakthrough discoveries based on the vote by ISN members. These are the top discoveries that had the biggest impact in advance in nephrology. And one of the breakthrough discoveries selected in 2020 was HIF and hypoxia of the kidney. The regulation of EPO was not well characterized until 1992 when Greg Semenza discovered hypoxia-inducible factor, HIF. Sir Peter Ratcliffe clarified the mechanism of oxygen-dependent regulation of HIF, and William Kiley Jr. demonstrated the essential role of von-Hippel-Lindau ligase in proteolysis of hydroxylated HIF alpha subunit. And chronic hypoxia of the kidney is believed to be an important target for therapeutic approaches because chronic hypoxia mediates progression of kidney disease. In 2019, the three outstanding investigators got the Nobel Prize for their discovery of the oxygen sensing mechanism. Greg Semenza from Johns Hopkins, Sir Peter Ratcliffe from Oxford, and William Cullen Jr. From Harvard. This is Greg Semenza, who discovered hypoxia-induced factor. And this is Sir Peter Ratcliffe from Oxford. He is the first nephrologist who became the Nobel laureate. This is the paper in which Professor Greg Semenza reported discovery of HIF. In 1992, he reported the new transcription factor, hypoxia-induced factor, as a novel regulator of HIF EPO expression. And 25 years later, this led to the Nobel Prize. These are the studies by Sir Peter Ratcliffe. He discovered how HIF expression level is regulated in an oxygen-dependent manner. These are the papers by William Cullen Jr., which showed the importance of proline hydroxylation by von Hippel-Lindau factor as a regulator of oxygen-dependent HIF expression. Why is this work important? Because this is a textbook discovery. This would be something students would start learning at the most basic levels of biology education. This is a basic aspect of how a cell works, and their research has implications for treating many diseases in which oxygen plays an important role, such as anemia, ischemic heart disease, stroke, kidney disease, and cancer. Oxygen diffuses from the vasculature to the resident EPO-producing cells in the kidney. Within these cells, HIF prolyl hydroxylase, HIF-PH, utilizes oxygen to hydroxylate HIF alpha subunit. When HIF alpha subunit is hydroxylated, it is recognized by von Hippel-Lindau protein and is destroyed immediately. Thus, under normal conditions, there is no HIF alpha subunit within the cell. However, under hypoxic conditions, HIF prolyl hydroxylase, HIF-PH, cannot utilize oxygen. HIF alpha subunit is not hydroxylated and escapes degradation. HIF alpha subunit translocates into the nucleus, binds to HIF beta subunit to make a heterodimer, and induces expression of many genes that are adaptive to hypoxia, such as EPO and VEGF, vascular endothelial growth factor. Hypoxia is a final common pathway to end-stage kidney disease. At an early stage of kidney disease, the changes of blood flow in the kidney due to the activation of the renin-angiotensin system or other reasons results in hypoxia of the kidney. In advanced kidney disease, fibrosis of the kidney leads to loss of peritubular capillaries. Fibrosis also increases the distance between capillaries and resident kidney cells, leading to lower efficiency of oxygen diffusion. So from the beginning to the end, hypoxia plays an important role as a mediator of progression of kidney disease. Other factors also contribute to a hypoxia of the kidney. Many patients with CKD suffer from sleep apnea, and sleep apnea results in hypoxia. This can also lead to fibrosis and endothelial dysfunction, leading to loss of kidney function. 20 years ago, we developed a new system to quantitatively measure oxygen tension in the organs. We established hypoxia sensing transgenic rats utilizing the HIF system. These rats express the reporter gene controlled by HIF ubiquitously. And by measuring the activity of luciferase, we could estimate oxygen tension of various organs in an oxygen-dependent manner, in a quantitative manner. And we demonstrated that the kidneys of many different animal models were hypoxic. William Kaelin Jr. Were studying the same topic, and they developed hypoxia sensing transgenic mice utilizing the same strategy. They published this paper 2 years after publication of our work. They used a more sophisticated technique, which is called IVIS, and visualized activity of the reporter gene in mice alive. When they put these mice in hypoxic chamber, the oxygen tension of the brain was kept normal until the end, while the oxygen tension in the body decreased. And oxygen tension in the kidney decreased dramatically. Their study clearly showed that kidneys are very sensitive to changes of oxygen tension. We also developed a new phosphofluorescence probe to measure the oxygen tension within the cells in a very quantitative manner. Using this phosphofluorescence probe, we can now analyze the oxygen tension of each cell within the kidney, within the tubules. As you can see here, in a very clear manner in mice alive. In patients, we cannot use these kinds of transgenic manners or probes. We use bold MRI, blood oxygen level dependent MRI. And many studies clearly showed that the hypoxic kidneys had a lower kidney survival compared with kidneys with more oxygenation. As hypoxia is a final common pathway to end-stage kidney disease, activation of HIF, which is a master regulator of adaptive response to hypoxia, can theoretically treat kidney disease. In 2003, for the first time, our group demonstrated protective effect of pharmacological activation of HIF in an animal model with kidney disease. After publication of this paper, many groups confirmed protective effect of HIF activation in different types of animal models. Recently, we showed the protective effect of HIF activation in animal model with diabetic kidney disease, BTBR OBOB mice. This is a typical type 2 diabetic kidney disease model. HIF activation improved metabolism. It increased diabetes, it increased insulin resistance, and it improved phenotypes of diabetic kidney disease. In patients with anemia in CKD, hypoxia in the kidney should increase EPO production. However, we showed that uremic states suppresses HIF activation. For example, indoxyl sulfate, a representative uremic toxin, induces HIF inhibiting cytid 2 protein Thus, under uremic conditions, patients cannot activate HIF in an appropriate manner, and this aggravates anemia in CKD because these patients cannot express EPO in an appropriate manner. This is also important for cardio-renal connection. Patients with kidney disease are known to develop cardiovascular complications. Because uremic patients cannot activate HIF, their organs are more susceptible to ischemic insults. So because of inappropriate activation of HIF, these patients tend to develop ischemic heart disease, stroke, and other types of cardiovascular complications. Now, HIF pH inhibitors to activate HIF and induce endogenous EPO expression are available at the bedside. In 2019, the Chinese groups developed these two papers. Other studies were also published. This is the INNOVATE study of varalostat, published by Kai Eckert from Germany and colleagues. HIF pH inhibitors showed the equivalent effect in treatment of anemia as darbepoetin. The MACE was similar between the two groups in the INNOVATE study of varalostat. This is the PROTECT study of varalostat. Once again, varalostat successfully treated anemia in CKD. However, there was a slight increase in MACE in patients treated with varalostat. The group performed post-hoc analysis of the PROTECT study, and they concluded that the higher MACE rate, which was observed only in the non-US, non-European varalostat group, may have been partly because of imbalance in the baseline eGFR level in countries where dialysis was not uniformly available, resulting in many kidney-related deaths. As you can see, many people, many people with eGFR less than 5 were recruited in this group. So this may have been the cause of this higher MACE rate observed in the protective study. This is the result of the ASCEND-T study of daprodustat. Once again, daprodustat showed the effectiveness of treatment of anemia in CKD. And the adverse events were not different among the group treated with daprodustat and group treated with ESA. This is the ASCEND-ND study of non-dialysis dependent patients treated with daprodustat. Daprodustat was effective in treatment of anemia in CKD. However, there was a slight increase of cancer-related death or tumor progression or recurrence in patients treated with daprodustat. As I said, one of the target genes of HIF is VEGF, so cancer-related events can be a theoretical concern. However, pre-specified on-treatment analysis for cancer-related adverse events resulted in a biased risk estimation in ASCEND-ND study by preferentially undercounting events in the darbepoetin arm. So that can be an artifact. We performed many clinical trials in Japan. These are the phase 3 clinical trials of varalostat in Japanese patients. We observed successful treatment of these patients with varalostat. We also performed phase 3 clinical trials of daprodustat in Japanese non-dialysis dependent CKD patients, HD patients, and PD patients. Once again, the treatment was successful. We also performed phase 3 clinical trials of enarostat in Japanese dialysis dependent and non-dialysis dependent patients. The treatment was successful. A recent paper in Nature showed that HIF activation by HIF-PH inhibitors induced expression of HP hemoglobin F, a fetal type of hemoglobin. We do not know what kind of consequences expression of hemoglobin F induces in the human body yet. There are many systematic reviews and meta-analysis of HIF-PH inhibitors, and most of these reviews and meta-analysis showed the equivalent effects between the placebo or ESA and HIF-PH inhibitors. Instance of myocardial infarction, instance of stroke, mortality, and so on. Other studies also showed the equivalent risk when HIF-PH inhibitors were compared with placebo or ESAs. Because HIF-PH inhibitors were first approved in Asia, the APSN published the recommendation of proper use of HIF-PH inhibitors in 2021. And KDIGO also published the results of the controversy conferences about HIF-PH inhibitors last year. There are many potential advantages and disadvantages of both drugs. HIF-PH inhibitors are oral dosing, more convenient, and it suppresses hepcidin, improves the utilization of iron, and effective in chronic inflammatory status. However, at the same time, there are potential polypharmacy, and we have less clinical experience in HIF-PH inhibitors. We have risk of enhancing tumor growth, although clinical trials did not show that kind of strict evidence. Oxygen is very important, and we have to treat anemia in CKD in appropriate manner. And now we have HIF-PH inhibitors to treat anemia in CKD. We have to use these reagents in an appropriate manner. Before ending my talk, I'd like to congratulate all our colleagues in India for holding World Congress of Nephrology in 2025. We really look forward to visiting you in New Delhi for this Congress. And WCN 2024 will be held soon. We are really excited about this as well. Thank you very much for your kind attention. It was a true honor and pleasure to make a presentation here today. Thank you very much.
Thank you.